Good evening, everyone, and welcome to the Illumia Kickoff Dinner. We are so thankful that you all took time out of your busy schedules to be here with us tonight. It's going to be a very informative evening. We have some really great speakers lined up. Before I introduce our speakers, there's just one item I'd like to cover with you. On all of your tables, there are cards for questions. If things come up as the presenters are presenting and you'd like answers to it, there will be a panel at the end of the presentations. So tonight, I'm sorry I didn't introduce myself, but most of you know me. I'm Dr. Pam Zalasko, Medical Director for Senior Health Connect. Tonight we have a series of speakers. The first will be Dr. Dave Lewin. He's a Medical Director for Senior Health Connect, a family physician at Grand Valley. He is going to introduce Illumia and explain why we think this program will be excellent for our patients, really provide great quality care as they near end of life. And he will also talk a little bit about how this program is going to help us succeed in full risk. He will be followed by Dr. Kevin Spencer. A lot of you probably know him. He has presented at many of our events because he's been supporting our network from day one. He's going to give us a bigger picture context overview. He has unique perspective across the country because he supports groups like ours that are already engaged with Illumia. He will be followed by Dr. John Copeland, who is a family physician at United Physicians. That's a group across the state. They have been partnered with Illumia for about a year and a half, and he is going to share some insights on his experiences with it, as well as some practical pearls and tips, what they've learned along the way. And then lastly, we have our keynote speakers, Elaine Ziegler, who's the president of Illumia, and Dr. Carrie Hyde, who is CMO. And they are going to provide a very detailed overview of the program. They will tell us how they deliver care to our patients and how they are differentiated from other end-of-life programs or palliative care programs. So without further ado, I'll have Dave Lewin come up and kick off the program. Thank you.
Good evening. Thank you, Pam. So again, my name is Dave Lewin. I'm, she said, one of the medical directors for Senior Health Connect. And since I'm 50 now, I'm wearing glasses. So here we go. Again, thank you everyone for coming out tonight. We really do appreciate it. We acknowledge that this is an ask, so thank you. But I think it's definitely going to be worth your time. I also wanted to take a moment just to thank everyone for your hard work in 2024. We made significant progress with burden of illness work, as well as strengthening our existing relationships within Answer Health. So or maybe even before we begin tonight's program, I thought it'd be helpful to provide a little bit of context to describe what we're trying to solve for here and how did we get here. Sorry. Over a year ago, I asked to be able to be part of our in-market palliative care program to try to see what are some things that we could solve for, because I'm personally very interested in end-of-life care. I, at one point, thought I wanted to be a hospice physician. So one of the first things that we did was we surveyed a whole cohort of about 20 to 25 PCPs here to get their experiences with our current in-market palliative offerings. And what we heard was a lot of frustration and a lot of ambivalence. Our docs, we all kind of conceptually understand what palliative care is for their patients, but we really weren't seeing it on a day-by-day basis. So, I mean, in truth, it's pretty hard to deliver high-quality palliative care in a fee-for-service market. We've got really good, hard-working folks that are doing this each and every day, but frankly, a little bit light on the resource side of things. So based on this feedback, we began this extensive vetting process of a number of different programs across the country, Agilon programs, each of who are doing things a little bit differently. And as a result of that vetting process, we saw that Illumia was representing kind of the best and most comprehensive program that would provide care for our patients and for their families. And you're going to hear about that tonight, of course. So who is Illumia? Learn a little bit more about it. So I'm going to give you some broad strokes here. So the Illumia program is made possible by the fact that we do value-based care. Through full risk, we can offer high-touch, in-home care at no cost to the patients if they are Medicare Advantage patients that have Priority Health, BCN, or Blue Cross Blue Shield, and if they meet eligibility requirements, which you'll hear about more tonight. Illumia's scope and level of service are just so differentiated from what we've kind of learned, from what we've been experiencing with palliative care, that we're actually calling it something different. We call it Advanced Illness Management, and you'll see why tonight. So I'll let the Illumia team kind of tell you about the program themselves, but I want to highlight what this will mean for all of our patients. It means, at minimum, 2 in-home visits monthly to see how your patients are really doing in between the times when they're not in your office. It means telephone support from nurse care managers and social workers in between visits. It means having a nurse come out to their home at 2 in the morning if need be, if there's an acute crisis going on. And then if it looks as though the patient actually needs to go to the ER, they'll actually accompany the patient to the ER to provide a warm handoff and make sure that the patient is advocated for. So as you can see, this is next level stuff. It's also real eyes on the ground, collaborative partnership with the Illumia team, because us as PCPs will remain actively involved in our enrolled patients' care. And one of the ways that we can do this well is to provide a best contact phone number for those rare situations when the Illumia provider really needs to reach us on a pressing clinical situation. Sorry. So I'm going to reference, there are cards on the table there where people can, if please write down again your best contact information. There's also a QR code here that you can scan if you feel more comfortable providing it that way. But what I plan to do is to put down my personal cell phone number, knowing that they will be contacting me only if there's an urgent clinical situation, and would ask that everyone do the same. This is a best practice that we've learned from other markets that really helps this program to succeed. So I think it's important that everyone realize, too, that this is a proven clinical model. This exists in 9 other markets across the United States. And we have data, which we'll share, that clearly shows the positive clinical outcomes for our patients and their families. And additionally, when I talk to PCPs that are operating in these markets, they are like kind of over the moon in terms of the care that their patients and their families are receiving. And they really feel like it helps them to be better clinicians to patients in this stage of their lives. So in closing, I'm really excited. This has been well over a year in the making about this partnership with Illumia, both as the medical director and also as a primary care doctor delivering care to folks. I view this as a true win-win scenario for our patients and Senior Health Connect, which, by the way, is all of us here in the room tonight. As you'll hear tonight, Illumia provides a real step up in the resources we have available to our patients. It also, and I want to highlight this point, this represents the single biggest opportunity in cost savings for our market. We spend 6 to 8 times the amount of healthcare dollars on patients in the final 12 months of their life. By reducing ER visits, avoidable hospitalizations, and then facilitating appropriate hospice transitions, this has a dramatic impact on medical expense, and we'll share outcomes on that as well. The other key point, though, is this program is not going to work if we do not use it. Early engagement with Illumia is going to be critical to our success in caring well for these patients in the final year of their lives. So think about those patients that you identified as palliative eligible during the recent APM activity that you did with your pod leader. I have gone through kind of my own list and identified the patients that I think would be best suited for this. And then it's equally important that we set up appointments with these patients in the next couple of weeks. And if that's not possible, which it's not for a lot of these people, I'm going to encourage all of us to make a personal phone call to those patients and explain to them what this program is and enroll them. Since we believe that these patients who are eligible, very well may be in the last 12 months of their life, it just makes sense that we get them plugged in as soon as possible so that they can be, experience the full spectrum of services that you're going to hear about tonight. So lastly, for anyone in the room that's kind of leery or skeptical of palliative based on your recent experiences or experiences in the past couple of years, I'd ask that you give this program a chance. Enroll at least 2 patients that you think would be eligible and follow along with them for the ride. I know you're going to come away very impressed. And then the next step would be talk to your colleagues about it. Let them know, what your patients and their families have experienced. Because again, I think this is a program that really kind of sells itself in terms of what it's going to be doing demonstrably for our patients and their families. So again, really excited about this opportunity. I feel we have a very good partner in Illumia that can help us with this very difficult group of patients. And before I finish, I did want to acknowledge Dr. Jeff Williamson, if you don't mind standing, Jeff. Jeff's going to be one of the Illumia medical directors. He has a wealth of experience. He's been doing hospice physician work for over 13 years. And, oh, by the way, he's also an Answer Health PCP, just like all of us. So that your involvement gives me even more confidence in this program. So thank you for coming, Jeff. So I'm going to turn the mic over to Dr. Kevin Spencer. As Pam mentioned, Kevin serves in a national role. He's going to provide us kind of the big picture on what's going on with Medicare Advantage and how Illumia fits in with that. So thank you.
Thank you, Dave.
Yeah.
Thanks, everyone, for having me. As Dave said, I'm Dr. Kevin Spencer. I've met many of you, but maybe not all of you. I was sitting in your seat 7 years ago when my practice in Austin, Texas, decided to partner with Agilon in a value-based journey, practiced in that model for several years, and now serve as the Chief Clinical Officer. And what I was hoping to do tonight, you guys are going to go very deep on the advanced illness management relationship with Illumia. And I could not endorse it more strongly. So I get to go around the country, and I've seen it work in all 9 markets. It's working in 9 out of 9 markets. You will be number 10. There will be 13 or 14 by the end of this year because it's working so well. We're trying to take this and give that same experience to all patients because we think they deserve it. Patients at the end of life go through a lot of angst and a lot of suffering, and we as a country have not figured out a model that works very well. And we think we've happened upon it. And I think something that Dave said is where I want to connect the dots tonight is the reason we can afford it and do that. Think about what he just said. 2 or more visits a month, RN at 2 a.m., someone accompanying to the ER, and the patient pays 0. It's because of the model that we're in, the economic model that we're in. That economic model has had a hard time recently. And so I want to acknowledge that, and then I want to tell you what many people much smarter than me, both in the public and private sector, are seeing in the industry that say that was a down cycle that we're coming out of. So when you read in the newspaper on the news that Medicare Advantage has had a hard time, and you see United Healthcare and Humana's stock going way down, the reasons for that was kind of a perfect storm. Many in the industry are saying it was like a 100-year flood. It doesn't happen very often when we look back over the last 20-plus years of Medicare, but some things happened all at once. One is the government got it wrong, and when they predicted what the rates were that we should be paid based on the utilization, they were wrong. And so the utilization came in much higher. The government also changed risk adjustment. So V24 to V28 that you guys have heard about lessen the amount of revenue in a business model like this by around 5%, depending on that. And then finally, every year, the government makes the star ratings a little bit harder. And so they made them significantly enough harder this time that some of the health plans miss being at least a 4-star rating. When that happens, they take 5% of their revenue away. You have to be 4 stars. So all of these things happened all in one kind of 2-year period in 23 and 24. So that was something none of us can control. And now what I'm going to share with you is why is that changing, and is it typical for it to change and be cyclical? So the other question would be, are we in the right business being in primary care at this time in our history, in our country? What are the factors? And again, these are public and private sector experts and people who work closely with the government that we interact with on our behalf at Agilon. And here's the backdrop of why we think the future of what our healthcare delivery, especially in primary care, is going to be. So what you guys heard about the silver tsunami about 10 years ago, right? Everyone was turning 65. Well, now we're 10 years later, so those people are turning 75. And most of them are still alive because we're doing a pretty good job keeping them alive. And so what you're seeing is the number of patients who are much older and with even more disease in our Medicare population is going up. Meanwhile, who's your competition? You don't have much competition. The primary care workforce, I don't think it advanced. There it is. The primary care workforce is going down. So we're going to have plenty of customers if we want to be in this business. Then you're seeing the growing senior population. So you have lots of seniors, and they're only getting older. And then we're in a Medicare Advantage model. So are those seniors picking Medicare Advantage more or less? And the answer is they're picking it more and more and more. So people who go to business school, which I did not, would say, wow, lots and lots and lots of customers, not a lot of competition, a real problem to solve that the government and private sector are behind funding because we have to solve it. We're in a pretty good place on a go-forward basis. So here's some of the things that are changing, and I'm almost done here. So the 3 things on the bottom have been very positive things. The payers need us more than they used to. People like Answer Health have very high quality and star ratings. So back when your segment of their marketplace, you're helping them perform better, that's worth a lot of money to them. It's mattering in our negotiations. So we're having better success with the payers overall. We'll talk in just a second. There's been an administration change. Not here to give any political speech. I don't even think about that. But the fact remains is this particular Republican administrations in general are more favorable to the Medicare Advantage model, and it appears they're doing that already. And finally, the other parts of our business model in primary care are more strained. Our rent went up, our labor costs went up, the payers are not paying us more on commercial rate. That puts a lot of pressure on us. We're finding that our 30-plus partnerships around the country, doctors are sitting in rooms like this and going, this has to work. This needs to work for us to be economically sustainable. And your level of engagement and your deepening understanding of the model and the way you're digging in for your patients, we're seeing better and better and better performance rapidly in 25 this year as a result. The 25 rates weren't great. We'll show you that. 26 rates look good. V28's fully happened now. So now we're on a level playing ground. It's not going to get any worse. Utilization is still, we don't know. People are saying probably 25's utilization looks like it's going to be a little better maybe, but still a little high. And we think 26 is better. And the star ratings, at least within the Agilon ecosphere, all of our partners, with you guys chief among them, do very well there. So as I mentioned the administration, what you're seeing here is the rate. So Medicare sets a rate on what each Medicare member is going to be worth. And then we risk adjust that. That's why we want us to tell the right story about our patient. How sick are they or how well are they? Because that you take that rate and multiply it by that. Well, as you see, the blue bars are Democratic administrations and the red bars are Republican administrations from 2011 on. And in general, Republican administrations raise the rate much higher. And if you look at our last 2 years of 24 and 25's rate, they actually lowered it. They lowered it at exactly the time that the utilization went as high as we've seen it in our country, which is why in a revenue minus expense model, that's not really good. Took my revenue down and put my expenses way up. That wasn't a good math problem. So the rate notice that came out earlier this year that was actually put out by the Biden administration says the rate's going to go up by 2.23%. Now, the Trump administration will rule on that, and the final rate will come out somewhere around April 7th. And so most people are predicting it's going to go even higher than that. So that gives us a very favorable rate going into 2026, if that is to happen. Now, I'm going to go very fast. One of the things I always get sometimes confused by when we bring certain aspects of the whole model is I always like to know, well, where does that fit into the model? Like, what are we trying to do? So Illumia is a very, very important part of the model, and the part of the model that it is on the cost side. So we kind of break the business into A, B, and C. Attribution, that's who are your patients on which health plans that we're at risk for, and are we getting that right? We're doing a lot of work on attribution, both in when they really are your patient, making sure you're getting credit for them, and we're also trying to do work on when they're not your patient or they're in a nursing home, we're no longer really providing primary care, and let's remove them from the risk pool. B is burden of illness and other clinical pathways. You guys have heard enough about that. But C is where we're really excited. And when you think about the things we do in clinical medicine, the two most important areas that we see in the literature and in our experience in Agilon is people who are definitely high risk, seeing their primary care physician more often, has better patient outcomes and saves money on the clinical costs where it's unnecessary. And as Dave alluded to, the biggest opportunity is in the last 12 months of life. And that's what we've not had a great program in our country in very many markets. Again, there's been no funding mechanism for it. And what you're going to hear tonight from Illumia and the type of service that your patient can get is really important. So that's where it fits into the whole model. We know we document well, we know we have to get the right patients in our risk pool, but how do we care differentially for them? You guys care really great for the 80%, 85% that are not super, super high risk. The high-risk ones need more of you. The ones that are going to pass in the next 12 months have to have a different level of care. Coming to a doctor's office does not suffice when you're in the process of passing away. And so that's where it all fits. So with that, I'm going to let you hear from Dr. John Copeland, and he's going to share real-life experience that's going on right here in the state of Michigan on the other side of the state that our partners on that side of the state, United Physicians, and have been working with Illumia for a while, and he's a wealth of knowledge and also is just a good friend of mine and does a great job taking care of patients.
Appreciate it. Okay, good evening, everybody. Thanks for having me. I really appreciate working with Dr. Zalasko, Dr. Lewin. Gotten to know them a couple of years ago and worked a lot with them over the last few years. On the southeast side of the state, we've got 37,000 patients, 180 physicians, 60 APPs, 65 different practices, 30 different EMRs, and the same exact payers that you have over here. So a lot of the same challenges. I've learned a lot from Dave and Pam and Dr. App and Mark and the pod leaders, so it's really been fun collaborating to improve healthcare in the state of Michigan together. I'm going to start with a patient story of mine. Joyce is an 81-year-old female who I've been taking care of for about 10 years. She's got diabetes, hypertension, stage 4 chronic kidney disease, AFib, heart failure with reduced ejection fraction, EF about 20%. And I looked back at her case after a hospital discharge in December of 23. She had 5 admissions throughout the year 2023. She was in the ER 3 separate times that didn't involve an admission. And we had just started our partnership with Illumia at that time, and I was looking for that first patient. And I knew at that time that I was going to give Illumia a shot. And so I had a meeting with her 2 adult daughters in the office. And Joyce has some mild cognitive impairment, so I wanted to make sure that conversation involved the family. The conversations don't all involve the family. And we got her enrolled in January of 24. And I watched her journey. I saw her every month in the office, and she was enrolled with a nurse named Stacy and a nurse practitioner named Nina. And I looked at the end, just at December of 24. Last year, she had 2 admissions, 0 separate ER visits, 1 admission for heart failure. 23, there were 3 heart failure admissions, and then she had 1 pneumonia admission as well. So when we talk about this model, we're not talking about going from 5 to 0 or from 3 to 0. We're looking at care that's differentiated for her. One of the things that our hospice colleagues will tell us is really starting the conversation with patient goals of care. Her goals were to remain out of the hospital and ER. Her goals included remaining in her 1,000 square foot house in Pontiac, where she had lived with her husband for 60 years, and she wanted to remain pain-free as much as she could. So we really rallied the troops around that story and around what she wanted. And again, I look back in 23, she did go to the hospital twice. One was in the middle of the night. Her Illumia nurse went with her and stayed with her until she talked to the attending ED doc and gave a comprehensive medication list that now included GDMT because of our heart failure focus on heart failure with reduced ejection fraction. So this patient's getting the benefit in the clinical model from better care, reduction of polypharmacy, chronic disease management, reduction of unnecessary admissions. This is a high touch point model. And the idea here, like Dave alluded to, is that she was seen 23 times in 2024 and had proactive visits with me monthly with no cost to her. The PCPs, and these are the things my partners ask about very fairly, every visit will be followed by a progress note, however you receive consults, like you would for any other specialist within about 48 to 72 hours. And then they're also doing proactive medication prescribing. So in Joyce's case, she's got Lasix, 40 milligrams there, and when she calls the nurse practitioner on a Friday night or Sunday morning, it's never noon on a Tuesday when you've got a spot at 1 o'clock. It's Friday night, Sunday morning. They can get her started on Lasix. Her baseline dose is 40 BID. They can double it, and she can see me on Monday morning. They've got my cell phone, and again, they've called me twice in the year about her, once on enrollment and once for a clinical question. And it was really nice at enrollment because she was reluctant when they came out to the visit, and the nurse practitioner showed her cell phone, and my name was in her cell phone with my phone number on it. So this moves on from a vendor relationship, which it's not, to a true partnership, which you'll hear from both Carrie and Elaine tonight. This isn't your typical, and you'll see all the branding here. This is reflective of the partnership. This isn't just Illumia or just Answer Health. It's both groups working together collaboratively. So they do have a call us first preference, and the best thing we can do is reinforce that in the office if once a patient's enrolled, to please call them if you need anything, because the nurse will be out. As Dave said, and as Joyce has experienced, they'll actually go to the emergency room with patients. That's a different level of care than we can provide or we're used to. And Joyce, again, has some mild cognitive impairment. She still has some polypharmacy. She needs somebody to advocate for her. And when she's in the ED and her family can't be there, what better person than somebody that sees her 2 to 4 times a month? She's now at the stage where we're having hospice conversations, and she's appropriate. She's now stage D heart failure. She's risk adjusted that way. It's what she has based on inability to tolerate GDMT. We've had to reduce her carvedilol. We've had to cut her beta blocker in half recently, and she still had a couple admissions in the last year. So she, by definition, is stage D heart failure, and she's the perfect kind of candidate to be in this program. So one of the things we've seen in our market, before we started in our partnership with Agilon, our hospice length of stay in Southeast Michigan was 7 days, really bad. In 23, it was 40, and currently it's 72. It's actually 95 for patients in the last 3 months. That 72 is blended from 12-month-old data. So I'm really proud to say that other markets are kind of in that sweet spot, which is 100, 120 days. And again, the whole goal here is to align the patient's care with their goals. Those goals can be dynamic. One of the things Illumia does really well, and it's one of the 22 things we're required to do on an annual wellness exam, is advanced care planning. They'll start that process from the moment they do an enrollment visit, and it's not an easy process. It takes iterations. They'll make sure the durable power of attorney for healthcare is in the chart. They'll send you a copy of it. They'll actually have the conversation, not just fill out the form. And you know, in a half-hour annual wellness visit, when there's 22 other requirements, that's not a one-time 5-minute conversation. They'll do that on our behalf. I think one of the messages here is we're not doing this alone in primary care anymore, now that we've got this kind of resource available to us. And then improve patient, family, and caregiver satisfaction. One of the slides that Carrie's going to have tonight is this inverse relationship from a UK study that talks about the quality of death and then dollars spent. So they're inversely proportional in basically every country in the world. The more money we spend at the end of healthcare, at the end of life in that last 12 months, the worse the quality of death score is, according to caregivers, according to family, and that's just a universal truth. In Detroit, we spend $4,200 per patient per month, often with chemotherapy being infused within 14 days of death, patients in the ICU who didn't want to be in the ICU, patients in the hospital who didn't need to be in the hospital, and polypharmacy is another issue that they'll tackle in the home. So how do we do this? None of us went to clinical training to be salespeople, and what we don't want this, and this shouldn't feel salesy. It's one of the reasons we've talked about advanced illness management and not palliative care. Palliative care for both patients, families, and the healthcare system has this connotation with hospice and end of life. And you can talk about it, and it won't really change. So it's been a barrier. And so all the patient-facing materials will say advanced illness management. And I would recommend introducing that to patients instead of palliative care. Using direct language. Instead of saying, I'd like you to maybe think about considering doing this, treat it like you would a cardiology referral or any kind of referral you would make where you actually want the patient to go. I'd like to enroll you in my partner who's an extension of my practice and works with me, who's available to me and to you after hours, the Friday night, the Sunday morning, the Saturday afternoon when you're not available. So I'd like to schedule this consult before you leave the office today. We see that when the patient leaves an office visit with a scheduled appointment or consult in hand, the enrollment rate is about 85%. If we wait for Illumia to kind of call the patient a couple days later, it's like 40 to 45%. So I would just kind of treat it with that sort of intensity, and you really want the patient to walk away with that appointment in hand. They're an extension of your care team, in-home telephonic visits. We in Detroit have seen a 35% reduction in hospitalizations and a 50% reduction in admissions. 5% is good. 20% is good. 35 is unheard of. We had a long way to go, so that'll probably level off. But that's a talking point. I know one of your goals is to not go to the hospital 5 times this year. Let's do something about that. And this is data with 600-700 patients enrolled. It's not a small cohort. We've talked about it being free. I think that's an important talking point. You've got large laminated cards that I recommend keeping near your laptop or desktop just to be a couple of talking points. This doesn't have to be a sales pitch. It's just a 5-minute conversation. And you don't have to be right. If you, in APM, think this patient has less than 12 months to live, fine. If you're not sure, send Illumia out for a consult. The patient will get benefit from that. They'll spend an hour, 2 hours with the patient. We're never going to get this perfectly, so you don't have to be afraid of referring in the event that they're a suboptimal candidate. They'll communicate back to put them into another care management program, either in your practice or through Answer or another resource that's available. And then there'll be more details, advanced care planning, during the actual intake visit. So who are the right patients here? We've talked about this decedent model, or this less than 12-month life expectancy. I've got 400 patients in my panel, so 3 to 4% of those patients statistically will pass away in the next 12 months. So basically, we've got 12 to 16 patients. I've got 12 patients currently enrolled in Illumia, and all 12 of them and their families are thrilled with the care they're getting, including Joyce and her 2 daughters. So how do we start here? We want you to discuss advanced illness management. I talked about the 85%. And this is up to kind of how you want to handle this. One strategy is if the patient has an appointment in the next 30 days, to leverage that appointment for this discussion and ideally have it result in a consult. Another even more effective way is for you to call your cohort. For most of us, it's going to be single digits, 6, 7, 8 patients. They're your sickest patients. Those are the people that really benefit from a phone call. I think about it like this. If I saw somebody last week and their next appointment's July, and they really have less than 12 months to live, if I wait for that July appointment, I've waited a third of their remaining lifespan to have them get these benefits, which will result in admissions, ER visits, polypharmacy, being full code when they shouldn't be full code. So I don't want to wait till July to have that patient enroll. Palliative prognosis scores. So Illumia has like a 200 variable score that's embedded in their EHR, which will give like a 0 to 20 score. By definition, if a patient scores 10 or higher, that's a less than 12-month life expectancy. But if they score an 8 or 9, we want to leverage your cell phone to say, hey, they're scoring an 8, am I missing something here? That's where the collaboration starts. One of our pod leaders had a patient score an 8, the NP shot him a text, he called back and said, this patient fell twice in the last 3 weeks. The score bumped from 11, from 9 to 12 based on that information, patient enrolled. So this is like any rule, it's not a hard and fast rule, it's just kind of a guideline to help enrollment and to really target the right patients. Okay, I've got one more story. I've got a 67-year-old patient of mine, Michelle, who is a retired attorney. She retired about a year ago. She had very mild COPD. FEV1 was reasonable. She was on one maintenance inhaler, had mild depression, and she came to see me after a DVT PE admission. And upon that admission, she was hypercoagulable because she had metastatic pancreatic adenocarcinoma. She didn't show up on my high-risk list because she was previously 67 and really healthy. I referred her to Illumia that day, knowing I wanted to get the ball rolling. 3 days later, the NP came out to her house, did all the paperwork, and Michelle was doing great. And her 3 goals were she wanted to travel to Lake Tahoe, she wanted to travel to northern Italy, and she's always wanted to go to Antarctica, which is the only continent she hadn't been to. She did the first 2 trips, and last week got back from Antarctica and said to me, you haven't smelled fresh air until you've been there. And now that I've smelled the fresh air, I'm ready to continue my journey through the end of life. And I know I'm getting close to hospice enrollment. And having Stacy come out to my house once a week now has helped me align with the care that I knew I wanted. And one of the things she did as an attorney is she worked on estate planning. And she had all that paperwork done, but she really hadn't thought through her end-of-life goals. And I'm thrilled that now, independent of her oncology care, I get to partner with her on her journey through the last 5 or 6 months of her life. So I want to introduce Elaine Ziegler, who's been an incredible partner. She has just been, again, this isn't a vendor relationship, feedback, cell phone conversations, collaboration. So Dave said that the Dream Team presentation starts now, so we'll start it with Elaine and Carrie. Thanks.
I think we could have just dropped the mic ourselves after he gave the patient stories and talked about what we've done with his patients. I want to start by talking about who we are in Illumia and just tell you a little bit about how we got here. Who we are part of a larger organization called Gentiva. You may be familiar with that name. We've had all kinds of names through the years. We've been in home care for 50 years. The reason that I share this slide and kind of start off is, one, I want you to have trust in knowing that we are a seasoned home care provider. Today, across palliative care, which includes our advanced illness management, Empatia, which is our community-based, and our hospice, we're caring for over 40,000 patients on a daily basis. So the amount of care that we're delivering is sizable, and that gives us a real opportunity to learn from what we're doing well and what we're not doing well. I know Dave touched on this, John touched on this. As an organization, and honestly, personally for myself, of my 19 years, I've been with Gentiva of my 25-year career, and 8 of that I spent in hospice care. And what I saw in hospice care was people crashed into hospice. You never heard a patient or a family say, wow, I really wish you'd have told me later in my journey. It was always, I wish I would have known this sooner. That myself and some of my team members that really kind of thought about Illumia, thought about palliative care, we just saw that there were so many gaps in care that was being provided to patients with serious illness at the end of their life before they're eligible for hospice. There is a gap where patients become seriously ill. They're bouncing back and forth to the ER. They're seeing their PCPs. They have specialists. They've got home health. And there's just nothing really to bridge that gap, and they don't know how to advocate for themselves. And so when we got the opportunity to partner with Agilon, honestly, it was like almost like the heavens opened. You don't get this many opportunities in your career to develop a model of care based off of what you want to do, basically the right thing for a patient. So when we talk about this, it for us is not just who we are at Gentiva. There's a lot of us who this is a really personal journey for us because we believe in this model and we believe in this care. That being said, this gives you an idea of why we believe so strongly in Illumia and this model. We know that this is an underserved and financially, not that you want to think about finances, but the reality is there's a reason you all got into the risk-based business, right? You saw or you see every day in the fee-for-service world, you have a patient that you come across that you think, man, I wish I could do more. I wish I could give them more resources, but there's just like nothing out there for them. And so we saw that as an organization, which is why we wanted to enter into a value-based environment and partner with PCPs. We know that as physicians, as providers, your relationship with a patient means more to them from a trust perspective. And when you recommend something, they're more likely to adhere and be compliant than if they hear it from somebody else, right? My parents are aging. My dad's 94. He's on our hospice service today. My mom's in her late 80s. And anything their physician tells them, it is the Bible. And I'm like, Mom, well, did you ask about this? Or she's like, no, he told me this is what I need to do. And I'm like, but did you ask questions? So I say that because the reality is the population that we're looking to serve, which is that advanced illness 12 months or less, they're looking to you to identify resources for them that can improve their clinical experience. This is, went too far. Let me go back. This right here is a study that was done, and if you look at over to the far right-hand side, the blue box, 70% of Medicare patients say that they want to pass away at home. 70%. 30% actually have that happen. So when we think about creating a pathway for patients to achieve their goals of care, and when you think about a patient passing away at home, that sounds really easy and lovely. But once it starts nearing the end, it's not so lovely and easy. And people aren't prepared for what's about to happen. And that's where we come in. When we start having goals of care discussion, advanced care planning 12 months up, when a patient reaches their appropriateness or their time of acceptance for hospice, we've had many difficult conversations and prepared them and their family and aligned them with appropriate resources so that they can smoothly and seamlessly transition into that. So Carrie's going to touch more over on the left-hand side from a clinical perspective about an experience with a patient, but I'm sure when you look at this graph and you see that, think about your patients, similar to what John was talking about with CHF, bouncing in and out of the ED, home health, then they may go and have a skilled nursing facility stay and get rehab, then they go back home, they get an infection, and it's just all over the place in their trajectory and how they're cared for in the system. The graph over to the right is to really show you once Illumia is involved with the patient, the seamless transition of them in caring for them in their advanced illness. It's managing that patient with you. It's prescribing patients as needed when there's an acute event. It's going after hours when they have a crisis. It's accompanying them to the ED if necessary because we may be able to mitigate a full-blown inpatient hospitalization. But the intention is to really smooth out that last 12 months and create a more predictable experience and not such a dispersed experience. So this just kind of tells you why Illumia was launched. I touched on it briefly, but we really wanted to not only align with PCPs and provide care in a different way, but to the speakers earlier when they were talking about CMS and the palliative environment, If you've seen one palliative program, you've seen one palliative program. You can go from company to company. We all define it a little differently because it's not regulated. And that creates confusion for patients, for families, for providers, for physicians. And so our vision was to establish a holistic approach to taking care of these patients in an interdisciplinary way that involves different disciplines, but not to create such a robust model that it mimicked or duplicated hospice. Because we all know if patients have an experience with people in their homes and become comfortable, then they're like, well, I'll just stay with y'all. I don't need to go to hospice. You're taking great care of me. So it is basically a taste of services to show them what's available to them. The other piece is we as an organization believe that there needs to be a standardized benefit for palliative care because it is such a large population out there. And by caring for more and more of these patients, improving outcomes and showing we can bend the cost curve and we can create great clinical outcomes and we can make it easier for patients and families, our hope and goal is to be able to present something to CMS that changes the industry and really gives these patients the benefit that they deserve, and a payment mechanism so more providers out there can take great care of these patients. This is how we, this is a bit of a busy slide, but what we wanted to show you before I jump into the actual clinical model is how we kind of surround the patient all the way around. So you see over to the far left, we have in-person medical management, so that's going to be by our nurse practitioners and our RNs. I'm going to go into their visit frequency and kind of what they do. They're more of the in-person planned visits, but then also on top of that, the urgent and crisis visits. Our remote interdisciplinary team, which is in the middle, is more of your proactive. So they're doing proactive outreach to provide interventions. They're doing everything from remote patient monitoring. They're doing care and disease-specific pathways. So if a patient has CHF, to John's point, we may put meds in the home, coupled with when that remote interdisciplinary team calls, they're asking very specific questions surrounding CHF, COPD, knowing that salt intake, shortness of breath, having to use pillows at night so that they can sleep. All of those things are indications that their diagnosis or disease state could be changing and they could be progressing. And if we are asking the questions in advance, then we're more likely to then go out and make a visit in advance that's more proactive and less reactive at a 2 a.m. crisis intervention call. And then I did mention the deployment of in-person. Down here, it's the PCP and the patient and caregiver in the center, always. They're at the center of our care. But the PCP and the care team, you're still the quarterback of the care. And I can't stress that enough. We're not here to take over for you. We don't want you to hand the patient off to us. We want you to stay involved. It's important to us. And not only is it important for us, it's important for the patient. And if you think about value-based care, we're all at risk together with these patients. And so we want to make sure that we are all clinically taking care of the patient at the highest availability. So that means they're still coming to see you in the office if they want to come see you. Just like John mentioned, he's still doing his monthly visits with his patient in the office. We're supplementing on top of that with in-person visits and remote patient monitoring. So these patients are getting, high touch is an understatement. I think probably one of the things that we do hear from patients sometimes if they are new to the program is they're like, wow, y'all really come out a lot and you call me a lot. Like, yeah, that's the point. So why do we do what we do? I think this is an important slide for you to see because this articulates, first of all, it breaks it out into the on-site support, which I did mention. And the little dots that you see that have a number, that's on average the number of visits or touches that that specific discipline makes in a month. So for instance, the on-site nurse practitioner is going to see your patients at least 1 to 2 times a month in person. The on-site RN is going to see your patients 1 to 2 times a month at minimum. It's based off prognosis, it's based off their diagnosis, and if they have acute events, we may need to go out, which is why we have a range in there. But at minimum, your patients will be seen in person in their homes by a physical person from the Illumia team every month. Then we've got our on-site support and then the remote care team. So the RNs reach out 1 to 2 times a month. They're altering their touch points with the people who are going out. So realistically, if your patient has had an acute event, or let's say they're less than 6 months prognosis and they have decided not to transition to hospice, they likely are being seen and or touched by our team every week. So our intention is, as patients' disease progresses, they need to be seen more often in order to actually improve clinical outcomes and keep them out of the hospital, or really address what's happening with them and what's changing. If you look at the bottom, and you guys are going to get these slides afterward, this is just what those specific disciplines do. Your really key point of contact in this relationship, you'll get to know some of the team members like the RNs, but the number one person that you will be interacting with the most is usually the nurse practitioner. What I will say, we get this at a lot of the meetings that we do when we launch is, well, who's going to be my nurse practitioner, because I want to know them, and can you tell me their name tonight, because I want to know who that person is, because they're going to be taking care of my patients. The reality is this is home care, and when we first launch a program and we're giving patients, they can live all over. So until we really get people admitted into the program and we get panels for nurse practitioners, we're a little bit all over the place in the beginning. Once we settle in and nurse practitioners get consistency in their territories and geographies, you will likely have the same individuals that you'll be interacting with over time. Similar to, John knew his individual's name because he interacts with the same people all the time. So it will take time as they build their panels and as you make those referrals, because patients will live all over your geography. They're driving around a 50-mile radius of Grand Rapids to come in and see you. So I just want to make sure that we make that point, because that's always, you're trusting us to take care of your patients and you want to know. A lot of our Illumia team is here tonight. We've already hired a lot of our people. We're continuing to hire. We will be fully staffed on day one so that we can come out of the gate and be able to care for your patients from the day that we go live. This is what a patient journey looks like. I think it's always important we look at it from a lens of what does it mean for us as a provider, but what does it look like for the patient? And for you to really see kind of what we do in conjunction with you as an Illumia team member. We do all of our starts of care or our evaluations are in person. We don't do it on paper. It's an actual nurse practitioner who's going to go out. They're going to do a med reconciliation. They're going to physically assess the patient. They're going to look at all your clinical records that you've submitted. And if the patient they feel is appropriate for the program, the patient will be admitted. If they don't and they're evaluating and they feel like, I don't know if this patient's the right fit for the Illumia program, then they're going to outreach to you, because maybe you saw something clinically that we're not seeing. You know the patient better than we do. You've had a relationship. Maybe they've had a sudden decline and it's just not documented yet, and you want to explain what's going on with that patient, because we want to make our best effort to get the right patients in this program. The other piece is the ongoing management, and I think that's really important, and I know Carrie's going to reinforce this, but our nurse practitioners treat and inform. So the whole point of us going into the home, being available 24/7, being available when there's a crisis or an urgent need, is that when something's going on in the home, we need to address it right then. Because we all know if we're like, we're going to make a phone call, and then we'll call you back when we hear back, and we walk out of the door, what's going to happen with that patient? They're going to get antsy. They're like, I don't know. What if I don't hear back from them? I'm going to go to the ED. So we do treat, and then we inform. That's why we want to have medical directors who are inside Answer Health, so that you have a peer, a partner, from a physician's lens. Are we going to get it right every time? No. So I just want to say that now. This is a human business. We make mistakes. I'm sure there's been times in your career where you've made a decision and you thought it was right in that moment. I say that to say we're not 100% perfect. And I think it's important for us to know that this is a relationship. And if we don't, then how are we going to address it together? It's not an Illumia and an Answer. It's a we. It's our patients once we've enrolled them. And we want to make sure we take great care of them. and we need your support. So that partnership piece is critical. And then last but not least is having those conversations surrounding hospice. Not all patients are going to want to go to hospice, and that's okay. There will be some patients who die on Illumia. They will choose aggressive therapies. They will choose curative therapies. We will take care of them. We will see them. We will do everything in our power to make it as comfortable as possible, and they may not choose. The other question that I get a lot is, well, you're part of Gentiva, and that's a hospice organization, so does everybody go to Gentiva? Patients have choices. So if they have a preference, if you have a preference, that's fine. We're still going to take care of the patient. We're going to take care of them just like any other patient. So I want you to know that our intention is to take great care of these patients. But it's also to have difficult conversations surrounding hospice. It's not an easy topic. A lot of people aren't comfortable with it. But our nurse practitioners are RNs. We do train them to have those conversations. And, you know, I do say when I'm talking to groups, we do teach people how to read the room. You know, like, you don't go in on day one with a patient that's like very resistant and doesn't even want to come on to Illumia, and we're like, well, let's talk about hospice because that'll go over like a lead balloon. So, you know, we have to understand where people are at, and we've got to meet them there. So we train our clinicians and our people to understand how to have those conversations. So now I just want to move in really quickly to our results, because I think it's important. We've said, well, we're going to do all these great things for your patients. And I know there's probably some skeptics in the room like, yeah, we've heard stuff like this before, but are you actually going to deliver? So this is our actual results from the 9 partners that we have across the platform. We've had almost 8,000 patients flow through between the end of 2023 and 2024 just in the Illumia program. So these are not small numbers. So when you're looking, this is not an N of like 100. So these results have been repeated over and over and over again. This that you're looking at is what we call our patient touch points, which I shared with you guys is what we do. If you're looking at this graph, the top is all scheduled visits. So these are visits that we proactively plan to go out to see the patient. The red is how many of those are done in person, and then the kind of yellowish orange line is how many of those are telephonic. In late 2024, on the back half, we started delineating our urgent visits so that we could pull it out of the EMR and show exactly what was urgent and what was. We have continued to iterate on this model with our partners as they wanted to see more and more data and really understand what's going on with their patients. So you'll see those urgent visits start to go up because we started really categorizing. But in the last 12 months across our partners, we've done 59,000 touch points to patients. So it is a significant amount of volume. When we come into a market, you know, we're hiring all local clinicians, but specifically for this Grand Rapids market, we probably will have about 35 people on day one ready to go to take care of your patients. So it takes a lot of resources to take care of these patients in this manner. You can see the other highlight that I have, the average. So we've iterated on the model over the last year. I won't go into great detail, but we recently moved more to an end-of-life model. When we first started this journey, it was kind of anybody that was sent to us, they could have any prognosis. And so when I talked about patients not wanting us to come out, imagine if you're a patient who has like a 2-year trajectory and we're like, well, we're going to come see you 3 times a month. And they're like, you know, they're still going to the grocery store and going and playing golf. They're like, I don't need all this. So we really thought about what are the resources that we have? What are we trying to solve for? And what population? So you'll see as we continue to refine the model and get the right patients inside the program, the number of touches per month per patient across our platform last month was 3.1. So, you know, that means every patient on average inside of Illumia, which we've got 2,700 today, got an average of 3.1 visits. So it's significant, the amount of clinical touch here. This is, John mentioned ADK and hospitalizations. We saw a 35% reduction in Detroit. We don't have those results necessarily in every market, but this that you're looking at is what we call claims-based data. So this is not us just predicting. This is actual claims that have come in from CMS that have validated what the hospitalizations were or were not. And for Q1 through Q3, for all of the markets that we have, we've had a 35% IP reduction in aggregate. So you can see, I'll point out one here for you, but like Dallas, we launched with them in January of 2024. So you can see our hospitalization, it's hard to get it under control. We were just admitting patients, but every month we've shown improvement, because the more we got in visits with patients, the more we got involved with them, we were starting to see that reduction come down. So tremendous results. And again, this is avoidable hospitalizations. There's still going to be patients who have falls and need to go. They have a heart attack, a stroke. We would anticipate that, but from an avoidable perspective. The other piece is hospice. We mentioned that. John mentioned the results that we've had in Detroit. This is the hospice length of stay by market. Today, this results only reflect patients that we've sent to Gentiva. Today, on average, across all of our markets, it's about a 55-45 split, meaning 55% of patients go to Gentiva and 45% go to other hospices. So there's some data not reflected in here, but patients still have the same profiles regardless of what hospice they're going to. So you can see the baseline hospice days was 60 days in aggregate across these markets, and we've shown improvement in every market related to hospice length of stay. Now, when you're looking at that hospice length of stay, that's discharge patients. So patients that are still on service and alive, they're generating length of stay. And the average today for those patients across the platform, for everybody that's alive, is 111 days. So we have definitely been able to move that needle. And really what I see that as is we're lifting off some of those very difficult conversations. You know, let's say you have a 15-minute slot on your schedule. And you're like, man, I really need to have this conversation. But it is not going to be a 15-minute conversation. If you're talking to somebody about hospice, you're talking about 45 minutes, an hour. Maybe their daughter needs to come. They need to have their son come. It's a family event that they want to speak and talk about what are the pros, what are the cons. And so we're able to take that time. The other piece is when patients are in their home, it's a very intimate setting, right? Sometimes they're a lot more open with us because we are on their playing field. We're in their environment. We're with their people. And by allowing us to come in, they're inviting us into their intimate environment. And that does sometimes allow us to have conversations in a different way. And we believe that that's partly what is helping drive some of the results that we're having. So I know we've said partnership, but that is really important to us. We want you to view us as an extension. Previously, when you think about a vendor relationship, you make a referral and you hand it off, and then you probably don't think about it again until you see that patient in your office and you're like, oh, you're looking through your note. Did you get so-and-so that I referred you to? There's no, you're just expecting the patient. In this environment, if you refer a patient, or let's say we schedule a patient because you direct schedule them in your office and the patient cancels and says, I've changed my mind, I don't want them to come out. We're going to call you and let you know, and we're asking of you to either follow up on with their next visit, like, hey, I recommended Illumia for you, and you chose not to have them. Tell me what's going on. Or, similar to what John was talking about, that you pick up the phone and call them as the physician. We've seen tremendous results in the Detroit program from PCP outreach. It's amazing when a PCP calls a patient, and they're not lengthy phone calls. The patient's very agreeable. We've gotten more patients scheduled by having the PCP outreach that were difficult, that had refused care, than we have seen across all of our markets. So when you're thinking about enrollment, don't think of it as a referral relationship. This is a refer to evaluate, but we all own it until the patient's enrolled. because you're still at risk and you're attributed for that patient. So it behooves you to have us helping take care of them. You saw why. We're going into the home. We're helping keep them out of the hospital. We're reviewing their meds to make sure they're being compliant, making sure they're not having polypharmacy. We're communicating with you if we feel like they need DME. If they have a wound and they need wound care or skilled care, we're reaching out to say, hey, we're going to prescribe home health for this patient and we're going to work in conjunction with them, because if we do that, that's going to be cheaper if they get an infection and have to go to the hospital. So that is, we're going to be your eyes and ears. So think about the enrollment piece we all own. If you identify patients, we've got to all work to pull that patient through and leverage whatever resources. When you get this deck in the very back, there's going to be in the appendix a direct scheduling. The best and most successful way to get a patient to convert is when you are in your office with your patient and you identify they need Illumia, that you have your office staff call Illumia with the patient there, and we schedule them before they leave. Just like you would if you were trying to get them into a cardiologist, or you were trying to get them in, to get a scan, or they don't leave without an appointment. If you don't want to go that route, in the bags that we gave you tonight, they're not just for the cups. There's some handouts in there, and we can give you more. But there is a prescription pad that you can hand to the patient that says, I'm referring you to Illumia because, and you can check it. If you don't hear from them, you need to call them in 48 hours. It just makes it feel more tangible and more of like, I need you to do this as the patient, and less about like, well, if you want it, great. That patient's still going to come into your office. They're still going to go to the hospital if they're not on Illumia. So we're trying to help you have a solution. And then there's also a referral form. If you choose to forgo direct scheduling, you don't like the pad, there's a referral form. It's a paper. If you like doing that, that's great. We'll print you more. Then in the middle, from a hospital avoidance, we've highlighted in orange our asks of you as a partner, and we're going to reiterate on this at the end of the night. But from a PCP perspective, from the hospital avoidance, there's one thing that we're really asking you to do, and that is when you see the patient or have interactions, that you are telling them to call us first. We're available 24/7, after hours, weekends, holidays. We want to be the one that they call first, and then we'll figure out what other resources they need. But if we don't know and we're not called, we don't have a chance at trying to really help and intervene on that patient. And then last but not least is the end of life piece. So we're going to do everything to tee up conversations. We're going to have goals of care. We're going to keep you updated on advanced care planning. But what we're asking of you from a provider perspective is, if we meet resistance and we both collaboratively feel like the best place for this patient is hospice, we're going to ask you as the provider to help reinforce that conversation, because you have that relationship of trust. Maybe we haven't had the patient for 6 months. Maybe we got the patient in Illumia, and 10 days after we got him, we're like, oof, this patient really needs to go to hospice. They don't need to be in Illumia. They're likely not going to take that recommendation from us. So it's a team and a tag team effort to say, hey, this is what we believe this patient's eligible for hospice. We feel like this is the best resource for them. Can you help us by having a conversation with this patient to facilitate that? So that's kind of our 3 asks. You're going to get this as well in the PowerPoint. But we are honored to be here tonight and to be able to help take care of your patients. I really believe that you're going to see a difference in the care, and I hope that as we continue to grow this relationship, that you will see the exact same results that we've seen in some of the other markets. But most, out of all the clinical outcomes and everything we can provide, I hope that your patients come to you and say, gosh, I'm so glad you sent us to Illumia. They're awesome. I mean, are we going to nail it every time? No, there's probably going to be somebody who's not happy. But overall, if your patients are singing praises, that's a reflection of you too. That's not just us, that's a we. And we want to create that experience for your patients. All right, I'm going to tee up Dr. Carrie Hyde. She's our Chief Medical Officer for Illumia, and she's going to talk about basically the clinical lens of Illumia.
It's always fun to be the closer. I don't know if any of y'all get to public speak, but there's no pressure here. So I actually give you a little bit of history. I don't know if you heard Elaine's Southern drawl. I'm also a Southern girl, and we're here in the beautiful state of Michigan. I was hoping to see a little more snow. I did see some in Chicago this morning. No, y'all don't want snow? Oh! Okay, little Arkansan me, I was just excited. So, really quickly, I just want to say thank y'all for coming in tonight. And I've had the privilege of talking to many physicians in Answer Health. And one of the things I continually hear from your colleagues is, we are a proud group of physicians. We take great pride in taking care of our patients. And we are here to do that with you. I actually am an internist. I'm a palliative care physician, hospice medical director in my past life, and joined this great company because A, it is going to change the future of palliative care. And when you think about your career trajectory, what do we want to all do is take care of our patients, and this is really the best program for that. What I'd like to talk about is this through the lens of your patients and through your lens. You know, why should I do this? Is this just another phone call? Is this another fax? I have a lot on my plate. You know, I didn't do primary care for a very solid reason. It's the hardest job in medicine. It is the hardest job, and I'm saying that as a palliative care physician. You do everything. You are the quarterback. You are everything to these patients, and I understand that it is hard in the current landscape. As we've been talking tonight, I'd be curious to know, show of hands. I know you're still awake because you yelled at me about snow. Have any in your mind 1 to 2 patients that you're like, I'm going to refer? Yeah. I know at least 1 patient that would benefit from this. That's really important. Keep that person in mind. Go ahead and get them in our program so we can continue helping. So I think John alluded to this earlier, but is anyone surprised by this? This is CMS claims data to show that in the last few months of life, the total cost of care is exponential. Anyone do ICU medicine, hospital medicine anymore? That was my foundation. It's exponential, the things we do to people at the end of life. But what's interesting is that as cost goes up, the quality of life goes down. Do y'all agree with that from what you see? Chemotherapy doesn't feel good. ICU stays, intubation, dialysis, transfusions. So total cost of care, as it goes up, the quality often is shown to go down. This is some data from our Agilon partners, really showing that when an Agilon patient enrolls in any palliative care program, what happens? And so the green line is just our standard everyday patients, right? And then the blue line, is if they are enrolled in a palliative care program. And you can see here that it exponentially, it saves inpatient admissions. I think you've heard that time and time again tonight, so we won't belabor the point. The top graph here is the way our current healthcare system looks. So our patients get sick, they get a diagnosis, they go to the hospital, their function and health goes down. And then they get a little bit better, you put them on rehab, they go home, they regain some function, and then they go back to the ER, they go back to the hospital, they get sick, and this prognosis curve looks different for everyone, but we've all seen patients like this. And then what happens? We go, all right, it's time for hospice palliative, and they die. And the average length of stay on hospice, does anyone know? I know that you said it, but let's just remove the dementia patients that live on hospice and Jimmy Carter, who lived on it for 2 years. The average length of stay, median length of stay, is about 7 to 14 days, give or take any given time. The hospice benefit is a 6-month benefit, and then with Illumia Health, you have a 12-month benefit. What we aim to do here is to change this prognostication curve so that the end of life, those last few months don't look like hospital, ED, hospital, rehab. It is in-home. We are leveling off this curve. We're getting palliative care involved for 12 plus months, and then you have that full 6-month hospice benefit, which is just a beautiful benefit. So who meets criteria? Who is going to benefit from specialty palliative care? And in our model, it's advanced illness management. If your patient has a serious illness diagnosis, and these are listed below, so heart failure, advanced cancer, malignancy, end-stage renal disease, those are the hardest, I'll tell you that. Cirrhosis, neurologic conditions that are progressive, and they have had 2 or more hospitalizations in the past year due to that serious illness, or they have uncontrolled refractory symptoms. Pain, shortness of breath, nausea, vomiting, itching, depression, anxiety, you name it, we are your specialists to kind of help with these things. You know the patient that comes in with the list? Do y'all have the patients that come in with the list and they go, Doc, I got to talk to you about this, 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 and they take up that 5% of your patient population that takes up 50% of your day because they're calling your nurses, they're asking for more help. This is where you need to plug us in to really come and augment your treatment plan. Let me just say this, prognostication is hard. It is an inaccurate science. I have been humbled many, many times, and I was trained on prognostication. I have said to a family on a patient I pulled, a ventilator on, they have hours to days. You better believe that person lived for another month. So it is humbling. You are not alone. And if you walk away from this talk with anything, it is refer to us. You heard John say it. If you go, I'm not really sure if it meets the 12-month, we are black and white. We like to know hard and fast a prognosis if this person meets this criteria. If it's gray, just send it to us. We are glad to partner with you and talk through what we are seeing in the home because that may tell a different story. But just know this. And I love this prognostication curve because I never saw this in my training until I did palliative medicine. Have any of y'all seen this prognostication curve? All right, 3 people. We're doing good. So what's interesting is cancer does really, really well until they do not. So I actually draw this out for some of my patients because they'll go, I don't understand why you're referring me to this program. What is so vitally important is to say, you do well until you don't. And I want you to have this in place so that when that decline happens, you're at home, which is what you told me you want. So cancer can be a little bit tricky because they do well until they do not. Typically, when they decline, they have 2 weeks or less to live, okay? End-stage organ failure. So these are our heart failure, our renal failure, and our liver failure. So these are that exacerbations. And I wish I could, actually, I think we do have a pointer, don't we? Oh, it's like reflecting off and pointing and zapping y'all's eyeballs. So they do well, and then they never regain baseline function. So if you look at that patient, think about your heart failure patients. They do well, and then they have that first exacerbation. They never get back up to baseline. And then they have another exacerbation, and they steadily go down. When a patient with heart failure, renal failure, and liver failure go to the hospital 3 times in a year, they are very highly statistically likely to die within 12 months. So just think of that. And I always saw patients in the hospital in my former academic career. And I always said, they go, well, I always bounce back, doc. I always bounce back. I go, I know. There's always a last exacerbation. And that's hard, right? Because they always bounce back. And then the last one is dementia. God bless our dementia patients and their caregivers, right? So one thing that we haven't mentioned tonight is the support that we give to our caregivers as well in Illumia Health. It's an incredible burden. They love mom, they love dad, but they try to escape. We actually have some escapers on our service, and our nurses are trained to, okay, let's lock the doors, let's get the life alert, or let's get rid of the life alert because we're not using it, we don't know how to use it. So there's a lot of value there for dementia patients, but they live for an extraordinarily long amount of time, but they have a very slow, steady decline. So once you diagnose dementia of any type, it really can take about 10 to 20 years for that final decline. So I put this slide together for this talk, and I think it's really interesting because as John alluded to, and I think he said in one of our prep meetings, man, I wish I had this launch meeting when we launched a year ago. So y'all are getting the best launch that we have to offer because we have learned a lot of lessons over the last year or two. Why refer to us? It's not an extra step. It's what You said 2% of your patient panel, 10% of your patient panel. It's a very small amount, but it's a high value add. So patients will receive goal concordant care, and you've heard all of the reasons why. We avoid the hospital because of our 24-hour nurse line, and it's not just a nurse line. If we need to go out to the home to see that patient, we do. That's really important, and that's not a benefit that any other service provides except hospice. But again, this is for the non-hospice patients. So we will avoid the hospital and the ER if this is their wish. We include comprehensive support services. Again, you heard about the touch points, the high touch points. But again, the point of we also support the families. We have teams that we can call on to help with all kinds of social work. We need to get mom these certain forms. We're going to be there to do that and support them. Goals of care discussions. How many of you have gotten a goals of care or discussion, got that patient on hospice same day in one meeting? All right, we got one. I've done it because usually people are pretty sick when I see them. It takes 5, 6, 10, 15 conversations. You start that conversation, hand the baton to us, and we're going to take it from there. We're going to hand it back to you, just like you heard Elaine talk about, so that we are partners and we are talking about the same things. I cannot tell you how many times in the hospital when I was doing consultations, well, doc, why are you the only one telling me this? But if I got another doctor, their trusted doctor to say, I really think that it's time to enroll in hospice, or I really think this chemotherapy isn't working for you anymore, they made the decision, okay? So it's really important that we partner with you on goals of care discussions. The other big thing that I think has been understated tonight is that we are your eyes and your ears in the home. How many times do I go into a home on an end-stage renal disease patient who's supposed to be on a low-sodium diet, and guess what wrappers are all over their table? Taco Bell. I'll go, okay, so we need to talk about this. Or I look at their medication bottle and they're not taking it right. There is so much value in that. You can only do so much in your clinical visit in the office. So let us be your eyes and your ears. I had a patient the other day that was tripping on rugs. My nurse pulled that up. You told that lady to pull up her rugs because it's a tripping hazard. We did it. So it's really important. We do environmental assessments and immediate feedback on medical concerns. I had a patient the other day, and I sit on all of our rounds, so know that we are being led clinically by a very robust team of clinicians. Mom has dementia. One of our patients started seeing the green aliens. I said, treat them for a UTI. We prevented a hospitalization. We fed that back to the PCP and said, do you want us to write the antibiotic, or would you like to write the antibiotic? Friday afternoon, that PCP was grateful. We kept her out of a long hospitalization. And what happens when you get hospitalized as a 90-year-old woman with dementia? You get sick. And with the flu and COVID, we prevented a really horrible outcome there. And we do that all day, every day. That's just one example. So I know that John gave some verbiage examples. I came up with these as well. And again, I don't think we had these a year ago. What works when you are in your clinic talking to your patients? I'm not trying to spoon feed you what to say. I know that you've got a little form that has some verbiage on it. But I always like to say, I would like you to have access to my home-based quality of life program. It's called Illumia. They'll visit you in your home and provide an extra layer of support. They are my eyes and my ears in your home so that you can live as best you can with heart failure, or insert whatever illness. Don't say that if they don't have heart failure. We're going to work together as a team to care for you. That's powerful. This is an extension of me, and I want you to have the best outcomes. I expect that you'll benefit from having someone check in on you. Who doesn't want a good check-in, especially some of these patients? So really important. I think you'll benefit from this. I know you'll benefit from this. My other patients have. And then typically I will anchor that in their goal. So if that family member says, I don't want to go back to the hospital, like John's patient, so that you don't go back to the hospital, and you can call them 24/7, and then they'll let me know. So what do we need from you? One last call. Get your QR code out. Scan your number in so that my nurse practitioners can call you. Again, it's not a huge call burden. It is just, let's collaborate. Let me write that antibiotic for you on a Friday afternoon if you're going on vacation. Let us support your patients because we're in this with you. Messaging to families and patients, and then just let us collaborate. Let us help you take care of them. Again, y'all are Y'all have been, in all of my experiences, some of the best physicians that I've gotten to collaborate with. And I know that I have a high standard of excellence in my own team, and we're going to meet that and hopefully earn your trust. And I think, QR code, and I think we might have a Q&A session. Oh. Thank y'all.
Thank you. That was wonderful. So real quick, I know we're getting a little late. Before we move on to Q&A, I wanted to again thank everyone for coming out to learn about this amazing opportunity. Also wanted to again thank our out-of-town folks for coming in and sharing your expertise. We are very appreciative. And then last but not least, I want to thank the people that made tonight actually happen. The people that did all the work in the background. So. And special shout out to Vicki Woodard, Matt Webb, and Laura Junker. So could we clap for them? Okay, so I'm a pretty simple dude, and I'd be remiss if I didn't summarize today's kind of next steps for each of us. So first, I'd really like to get our Illumia providers busy very, very quickly. They're going to start accepting referrals on April 9th. So again, let's fill them up quickly. Second, go back and review those APM lists for your patients and those that you identified as palliative eligible. And also, remember that think about those patients that you wouldn't be surprised if they passed away in the next year. Those are the people that I would like us to get them scheduled, or if that doesn't work, let's pick up the phone, let's call them up, let them know about this amazing opportunity, and get them signed up. I would like us to do this with all of our eligible patients. Like John said, it's not going to be a big number, but let's say you're still on the fence about this. Give Illumia 2 tries to prove to you that this is going to be of benefit to your patients and to their families. And then last, I do want to beat this horse pretty dead. Give the phone number. This is the way that this is going to work. Again, it's going to be a value added for us. They are our eyes and ears on the ground. Let them help us. So there's the QR code again, or you can write it on the card on your table. Okay, I'm going to ask the presenters to come up on stage. We have a few, I assume people have questions. So we'd like to get to those if at all possible. So I assume
Great job. Nailed it. That was awesome.
cards are coming around.
When you're glad you didn't wear a dress. Just saying.
Elevated stage.
I did this last weekend.
All right. Again, thank you, everyone.
Of course.
So we're going to start with a real softball, and this one's going to Dr. Hyde here.
Ooh, yay.
All right. How does Illumia handle prescribing pain medications and controlled substances?
Yeah, so that's a great question. Did y'all all hear, how do we handle controlled substances and pain management? So through what we have learned over the course of the last year, we are not a chronic pain specialty clinic. And I know that's a huge deficit in the United States. What I would say is that we typically and do often prescribe controlled substances for patients who need them related to their terminal illness. So that patient with osteoarthritis of their back but also has CHF, we will not write pain medications for their low back pain. But we will, let's say if they get dyspnea and more toward the end of life, we may do a low-dose morphine for them, which is evidence-based for dyspnea. So if they have metastatic cancer, we often manage that. Pain-wise, if they do not have you prescribing or another pain provider. But typically, and I think it's worth saying because it is a point of contention, if you think you're referring for chronic pain management, we will disappoint you every time. So if there's a question and you need a colleague, I have cards, you can call me, I can get you connected with someone who could maybe help with prescribing, but not our team. We're just not set up for the safety of that with our patients.
So there's probably about 8 to 9 questions which are all the same. So this will be for Elaine. Does Illumia provide their palliative services in outside of the home? Independent living, assisted living, memory care?
Yes, Yes, so anywhere that a patient would call home, except for obviously a hospital, we would care for the patient. So the only stipulation that I want to say here is sometimes in skilled nursing facilities, they want us to get credentialed, our providers, so we can go through that credentialing piece, but that could be a slight delay if the facility is incorporating that. Sometimes they don't understand because we are community providers that we would have the same as a physician that's going in there or something. But otherwise, yes, independent living, assisted living, skilled nursing facilities, memory care, we can care for those patients within those places.
So the summary would be if you think the patient's eligible,
Refer.
they'll go where the patient is.
Correct.
All right, this is for you, Kevin, here. Different speakers have mentioned there is no cost to the patients. Who's paying for this?
Love whoever asked that.
Elaine can help as well. So we, in our partnership with Illumia, we pay their fees up front out of the partnership, and their fees are at risk. So if they, in the end, if they're not getting the results, which I can't believe they wouldn't since they've done it 9 other times, then they would have to pay our risk pool back. So we're paying their fees at cost on what it takes to hire those 35 people. Those fees are paid every month so they can run their business. Then we look at the results, and if they save money over a certain standard, then we split that with them 50-50. So what we're seeing is the total cost of care goes down. Illumia doesn't make any profit but is covering their cost, and then their profit only comes if they actually benefit your patients financially and with outcomes, because the only way we benefit financially is if the outcomes are good. So that's how that works. That's why you can't hire 35 people and go into the home with a nurse practitioner and bill a 99214 and give that kind of care. It just doesn't work. So it has to be in a model like we're all in today. And that's why they are after writing the white paper for the United States of America that says we have to do this better. And CMS, you should cover this in a fee-for-service world, because you actually will, just like we're going to save money and do better, the country would do better if they would actually be more thoughtful and have the forethought to pay more for the people a little bit earlier, especially knowing that people are resistant to going to hospice. They're not very resistant to say, someone I trust that is part of my team that I can meet with regularly, that has my cell phone number, is also going to care for you with me. Then patients are more likely to accept that, especially if you call it advanced illness management instead of palliative or hospice.
Great.
Elaine, did I get that right?
You got it right.
Next question is for John here. It's a two-parter. Could you again go over kind of the evaluation list and admittance or acceptance criteria used to determine if somebody is appropriate or not? And then do we have to use the fax form? Can we talk a little bit about how you guys are doing it in terms of getting these folks referred?
Sure. Yeah, so you've got a panel. Basically, your entire panel is eligible. We use an algorithm similar to how we use the Agilon algorithm. That's about 10 to 15% of your entire panel. So let's use a 200-patient panel. You'll have 30 patients on your high-risk list. Roughly 6 to 8 of those patients will likely have a life expectancy of less than 12 months. Like my patient, Michelle, though, at the point of care, and this is what I love about the model, you're the decision maker. So at the point of care, if you make a judgment, you don't have to wait for claims to catch up or to have them show up on a list. Your entire panel is eligible for this level of care, should you see fit. And then the second point is we really learned initially to kind of passively wait for appointments. Like I said, wait for the July appointment, wait for next month. And there's a lot of different places where that can fall through. You're busy, it's a patient complains of chest pain, your office manager's out on PTO, and so there's places where this can fall through. In the last 2 weeks, really, we've had our docs take their panel, sit down with one of our lead operators, and call all 6 patients. Most of the time, like 5 out of 6 will answer, and 5 out of 5 will agree to schedule a consult. So it's really this model that puts your clinical judgment first, and it's not just derivative or algorithm based. So your entire panel would be eligible for that level of care should you see fit. And again, if they sort of say that the first 2 that you refer aren't appropriate for this level of care and belong in care management through your practice or elsewhere, that's fine. Don't let that be a barrier to referring that 3rd one in.
Yeah, no, but I would add from the prognostication perspective, one thing we've learned just from talking to some of the physicians and also from our hospice background is always using, as you're thinking about, well, I'm not sure because we know prognostication is so hard, using the next holiday as your marker. Next Easter, would it surprise me if this patient were to pass? Because in your mind, that's something easy for you to think about. So whether it's Easter, July 4th, Memorial Day, you're always thinking about that next holiday. And when you're looking at that patient, you're thinking, wow, there's no way they're going to make it till next Easter. That's the patient you need to refer. That's standing in front of you that may not be on a list, but clinically they're declining, and you're watching that decline happen before your eyes.
Great. Could I just follow up on the point you made there, John, with another question? So if a patient is referred, you've taken the time to explain to the patient why you think they should be referred. Illumia comes out and says, hey, we don't think that this person actually meets criteria. How is that then explained to the patient, and so that you don't maybe lose face?
Yeah, that's a great point. Again, this is where we want to connect. I think of care management as a continuum. In my practice, we call care management light. We've got a couple people that are managing insulin dosing, nurses that are in the office managing fairly healthy patients. That's on the far left. Then we've got United Physicians Care Management, or larger practice-based care management. Then we've got Illumia. Then we've got Gentiva. So I'll explain it, that you're not quite at this point of the spectrum. You're a little further left. Patients will go back and forth, but these teams are collaborating, talking, interdisciplinary teams, and moving people left and right. And basically, a lot of the times they'll self-refer, and we saw this initially, is like Elaine said, they'll look at the intensity and say, I don't need that. So those are the patients that will actually refuse. If they have a 2-year life expectancy, they know that. So we don't really see a problem with saving face. It's really the messaging that this is a continuum of care, and you can move left and right on that continuum.
And I would say on our end, if our nurse goes out and evaluates and says, it's not time yet, that's a very warm transaction. And it's a very, call us back to both the primary care and the patient.
Yeah, I think that's important. Like it goes both ways. One is maybe it's looking like the opinion is the prognosis is more like 18 months. Well, that means in 6 months they're going to be eligible. Now they've met them. You guys have already talked about it, so you'll revisit that. Similarly to they go out to see the patient, and they need to be in, and they know they need to be in, and the patient gets uncomfortable and won't enroll. Then again, that may take 2 or 3 conversations by you instead of 1. So I think it's thinking about this as a continuum is important.
Yeah, and evaluation is always an easier word that's more digestible. Hey, I would like these individuals to come in and evaluate you for their services as my partners. You may or may not be the right fit, but I think if you are, this will be a great benefit to you. If not, they'll help identify a different resource that might be better suited for you. So using evaluate's a safe word for you. It doesn't hard define that, yes, you're eligible. It's more of, I'm seeing some things that make you likely appropriate for this program, but I'd like them to come out and evaluate you as my partner.
And meet that team. I want you to meet the team, because eventually they may need us.
Yep.
Excellent. All right, Illumia Dream Team. Okay. Once a referral is made, a consult requested, how long before an evaluation or determination is made for, and when is that first contact? So what can the doc expect?
Yep. So first contact, if you don't direct schedule and you just send a referral through traditional means, we reach out same day to the patient. In the beginning, when we take the referral volume, they're all going to come in probably. We're going to hope that all of you identify 2 patients and they all come in at one time. We will schedule those patients, hopefully in pods. So it could take 7 to 10 days to get all those patients. Once we get the initial bump of patients, because we got to fill the funnel a little bit, on average, it should take, once that's done, 3 to 5 business days. And businesses were 7 days a week. So 3 to 5 days to get out there and see those patients and get that initial evaluation. Once that evaluation is completed in the home, if that patient's borderline or we don't feel like they're appropriate, you're going to hear from our team within 24 hours. If the patient is, we send a report every day that is an end-of-day report, so your ops team is going to know every day the status of every referral that has been sent to us. We tell exactly where they are, if they've been contacted, if we've left a voicemail, if we've left 4 voicemails. Then if they're scheduled for admission, we have the date in there. So there is constant communication between us and you on a daily basis so that you know exactly where your patients are and how they've been contacted. And I see John shaking his head. He's seen this report. It's pretty extensive. And if they refuse our care, there's a process for that. We've been working with your operations team on those specific back-end processes on how we'll communicate with you. Everything from if the patient refuses care, if we've called 3 times and they haven't answered the phone, what that process needs to be. So everything through the implementation process has been nailed down with your ops teams of the points of contact, who we need to call, how we need to communicate it, and then what that follow-up looks like. But you can expect in the beginning, we used to say we would get out in 3 days, but then we would get like 200 referrals on the first day. And I mean, even with 35 people, that's physically impossible to see all 200 in one day. So we'll have them staggered out, but you'll know exactly where those patients are going to fall. Once we get steady state, you can expect 3 to 5 days.
Great, thank you. All right, next question. There's a partner operating near the lakeshore with the name of Empatia. Is this a spinoff?
Oh,
What
spin-off.
can you tell us about their satisfaction rates?
Yeah, so Empatia is within our family of brands. Empatia is actually our community-based palliative care. If you may or may not be familiar that we went through an integration. We integrated Heartland into our business. We've got a waiver over here. He's very familiar with our business. He and I spoke. And it was called ProMedica. We changed that to Empatia in 2024, but that is specifically for non-risk-based business. So it's the traditional mechanisms of your 99214s, and it is a very scaled-back palliative care because of the financial mechanism. So it is solely a nurse practitioner program. We don't have interdisciplinary like we do inside of Illumia, and definitely not at the touch points that we have. Most patients are seen on average about every 30 to 45 days, and because it is a fee-for-service program, there is an out-of-pocket and or deductible cost depending on what the patient's payer source is. So from a satisfaction perspective, still the same. We still drive towards the same results, everything from advanced care planning to hospitalization reduction, but not at the level of partnerships like we have in this model. So we're more of a consultant type community-based provider, less partnered like we are here, where we can really drive some major results because we have access to the patients and have such high touch. But yes, I actually oversee the Empatia. They are in my Gentiva Palliative Division portfolio that I oversee.
Great. All right, we'll try to wrap up here. Because that brings up an important point. This program is available for the folks that we're at full risk with, right?
Correct.
Which I mentioned earlier. So these are our Medicare Advantage patients that in our market have priority, BCN, or Blue Cross Blue Shield. So we will still be using community partners, whether it's North Star, whether it's Empatia or whatever. There will always be a role for them for our other patients that are straight Medicaid or Medicare, excuse me. So that, I'll send you home with one more here. So if I have a patient currently working with another palliative group, how would you transition, or would you, or should you transition? That's a good question.
So my question, when you're thinking about your patients that you have on palliative today, traditional community-based, the first question would be is where are they at in their prognostication? If your patient on palliative is 18 to 24 months out, they probably need a very low-touch program, and they're not quite ready for Illumia yet. If you feel like your patient has a prognosis of 12 months or less, and they are within your risk and attributed population, then I would recommend that you transfer them. Even if it's our Illumia, even if it's our Empatia, we would transfer them into Illumia because that patient is going to receive better clinical care and so much more because of this relationship. And you're going to see better clinical outcomes overall for that patient population that you have at risk. So, what I would say is the way to transition is you've now moved into kind of a different phase of your advanced illness, and I believe that you would benefit from a higher touch program that's going to see you more often. They're going to outreach to you more often. They're going to communicate directly with me. and I think that you would really benefit from this program.
Wonderful. Thank you, guys. I know that we promised you'd be out at 7:30, so we lied. Sorry about that. I want to thank you, everyone, again, for coming out, and again, to everyone up here. Please use the time afterwards. If you can stick around and kind of do a little networking, I think that would be great. Again, thank you for your time this evening.
Thank you.